Hello, everybody. I've had almost no sleep. I've flown 14 and a half hours, so what follows in the next hour could go almost anywhere. So forgive me. I've also had a series of people coming to me and telling me how wonderful yesterday was, which is slightly disconcerting for today's opening speaker. Just for clarity, it's wonderful to hear how yesterday was, but when people come with that grin on their face and say, Dave was really, really good, you're thinking there's an agenda here that's maybe not quite the same. So it's a wonderful privilege to be here. Christina, I'm not quite sure how she persuaded me to fly to Vancouver for 24 hours, but she did manage to do it, so here I am. And before I start, I'd like you to do the tweeters in the room. So my Twitter name is just my name. It's just @Jason Leitch. I have 24 hours in Vancouver tomorrow before I fly home. What should I do? So I'd like you to, genuinely, I'm serious, I'd like you to tell me what I should do. I have 24 hours in Vancouver. I can sleep when I'm dead. I'd like to do something. I've been before, briefly, so I don't know your city well, but I know it a little. So if you wanted to tweet advice about, don't do it when we're talking about healthcare quality, that would be inappropriate. But tweet me what I should do in Vancouver. I've already had some advice from a young man who seems to be a hockey fanatic that I should be going to the hockey this evening. Does that seem the right thing to do? Okay. And cheer for Minnesota, I understand, is how that should work. I'm not going to talk about curling. Since your evil male curling, my phone, your evil male curling team, just because they were bad boys and our guys were good boys, managed to beat us. So I'm not going to talk about them, but congratulations on beating the Americans at hockey. I like that. But only because we don't have a team. Let me take us back to perhaps why we're here this morning. My subject is the transformation that we've seen in Scotland in terms of healthcare quality. We're not done. We're just a tiny example of perhaps some of the things that can be done. We spend quite a lot of time as Scots going out to try and learn from other countries, so there's a huge amount to learn here. I have learned a great deal from your country and from British Columbia, so I don't present the Scottish story in any way as complete, so please don't think that that's what I'm doing. But let me perhaps take you on a little bit of a journey through the Scottish structure and then a little bit of where we are, particularly around healthcare, and then I'm going to end, hopefully, with some thoughts about where we're going next, breaking down the healthcare walls a little bit. I'm an oral surgeon. I'm a head and neck surgeon. I was a dentist and then became a head and neck surgeon. And now I talk much, much more about multi-agency work, about social care, about population health than I ever thought I would. And let me start here. This is Lucy and Lewis. Lucy and Lewis are a real family. I have permission to tell their story. I've met them a number of times now. Lewis is the cutest boy in Scotland, you'll notice from the image. Lucy is a recovering heroin addict. When I took this image, she hadn't had heroin for 3 months. She has a 6-year-old daughter who's in long-term looked-after care. She'll never see that daughter again, probably. And Lewis has never slept at home. He's 6 months old. He's never slept in his own bed. He's slept in a series of foster care homes. Not bad homes, but he's never stayed with his mum. 6 weeks after this image was taken, Lewis went home for the first time, unsupervised, and now the family is together. They're living in supported, supervised accommodation, and Lucy is on methadone and recovering from her heroin addiction, and it appeared there was hope when I met this family. When you first meet Lucy and you ask her what it feels like to be inside this system that we call health and social care, she describes a system of 16 organizations trying to access her to help her. Addiction, criminal justice, health, social care, all kinds of people. Well, she doesn't draw it like this, but it's like an organizational chart with solid lines down to where Lucy is. And this region in Scotland, which is in the centre of Scotland, have abandoned all of that, and they have co-located all of their services in one place. They have forced the organizations to work together in the nicest possible sense. They don't all wear the same color polo shirt. They haven't gone that far. But it now feels like a concentric set of circles around the family. Now, I told you I'm a facial surgeon. I've dealt with facial fractures my whole life. I understand the chaos may return to this family. I'm not naive. I'm not stupid enough to think this is solved. But it appeared to me there was some hope in Lucy and Lewis's life going forward. The most interesting part of the story was, and the moment where she made me cry, was right at the end, after I'd spent an afternoon with her. I said, "What do you want to do, Lucy? What's your hope?" And she said, "I want to be a drugs counsellor." So there's an asset that's kind of been created by adversity in Lucy that we will now use in co-producing a solution with Lucy and Lewis and for the future of this region. That's the hope we're going for in Scotland. So as I talk to you about charts and structures and numbers and perhaps show you some data, I want you to remember that behind the dots that I show you are Lucy's. So you need to understand a little of the politics of our nation. We're 5 million people. This is the Scottish Parliament. The building just behind the Scottish Parliament is the civil service, not the one with no walls. That's an old ruin on the top of Carlton Hill. So I work both inside the Scottish Parliament, which is our parliamentary building, and we have a big, old, horrible, industrial 1930s civil service building that they make as uncomfortable as they possibly can, so the newspapers can't say that the civil servants are living in any form of luxury. I'm going to show you a 4 or 5 minute video of the history of Scotland. It's a relatively short version of the history of Scotland, but it may give you some idea of where we're headed to the referendum on the 18th of September, which is a hugely important moment in Scotland's history. Everybody with an address in Scotland will be asked, do you wish Scotland to be an independent country? Yes or no? If 50% plus 1 vote yes, in 18 months will we be an independent country. If 50% minus 1 vote yes, then we won't be. I'm very happy to talk about that. That's not why I'm on the stage to talk. We can talk over coffee. But inside there is the devolution settlement, the 1997 devolution settlement, which was when the Parliament was reopened. I'm not sure that any Scots ancestry people in the room, when the Speaker of the Parliament said this was dissolved in 1707, it is now reopened. That does get you a little emotionally if you're Scottish. So that was a very important moment for us. And at that point, we became responsible for many of the public services in Scotland, including the National Health Service. So if you learn nothing else from this Scotsman, I want you to remember there are 4 NHSs. There isn't one. So there is no such thing as the NHS. There is NHS England, NHS Scotland, NHS Wales, and NHS Northern Ireland. They are entirely different. We have roughly the same terms and conditions for the doctors and nurses, but everything else is different. We have no trusts. We have no payer-provider split. We have no commissioning. We have nothing of the reforms that are going on in NHS England. Again, that's a whole other lecture, but I think you can sense in my tone where I think that should perhaps go. This is what Scotland looks like from space. It's each health delivery system is a different tartan. You may have not known that. And we divide our delivery system into 14 regional systems. We're about 500 or 600 miles from top to bottom, so we think we have rural problems until I come to Canada and then I hear about rural problems. But we do have some islands. We have some slightly odd people who live right in that. See that bit with the blue fence around it? That's actually a fence to keep the Shetland people in because they're a bit weird. No, it's not. In reality, the geography would be that would be somewhere on the ceiling, closer to Norway than Edinburgh, and about 20,000 people. And then Glasgow, the finest city in the world, 1.5 million people, 7 acute hospitals, 45,000 NHS employees, big, big delivery systems. We have integrated primary, secondary, public health. Each board is responsible for all of the healthcare for that population, not just the hospitals. We have no chief execs of hospitals. We have chief execs of healthcare delivery systems. And then we have a central management structure, a government management structure of a chief executive of NHS Scotland and then directors. And I am the clinical director of that piece of the puzzle. Excuse me, I've got a stinking cold. We've just passed an act in Parliament to move towards true health and social care integration. So care at home care homes, all coming in to be managed centrally. So that's the Scotland in a nutshell. But here's some of our challenges, not unknown, I think, to the Canadian environment. There's no money. So the money is gone. We can discuss where it went if you wish, but it's a relatively fatuous argument because it's gone. There isn't any more, and it's going to take to 2025 for our public finances to be spending the same as they were spending before the crash. So that's a 39 billion gap in our public finances. We spend 12 billion a year in the National Health Service in Scotland. So there's no money, and for lack of a better expression, there are too many old people. That's slightly unfair. My father doesn't like that particular sentence. This is 1911. Everybody died of infectious disease. There was a huge number of young people, massive families, but a lot of people died in their middle age. And then if we click through the years up to 1991 and 2011, which looks like a cruise ship coming to get you, don't you think? That's the demographic cruise ship coming to hit us over the head. People of my age in that bulge, 40 and 50-year-olds in that bulge, because our parents had a lot of sex 30 years after the war. That's roughly what happened. So big population boom after the war. They seem to have a lot of sex and a lot of children. That bulge is there. My generation, lots of sex, no children. Which is an entirely different way of living, but nonetheless. So there are many fewer children in the bottom, but you can see the tax base is now reducing. This is not, your demographic cruise ship would look not unlike this. So fewer people to pay taxes, a lot of people living into their old age with multimorbidities, which is a wonderful joy that half of the children born in Scotland today, half of the female children born in Scotland today will live to 100. Well, that's terrific, but it has massive implications for the delivery of public services. Scotland has some unique challenges. So those two challenges are global. This is unique. Scotland has lost control of alcohol disease. We've completely lost control of it. Now, there's been a caricature of Scots that were drunks. That hasn't been true. It is now true. So we haven't deserved the caricature for the 100 years it's been around. Now we absolutely deserve it, particularly in young men. So this is alcohol-related mortality in Scottish men, the red line, and you can see the other 4 countries of the UK underneath. And the red dotted line, if you can see it, is women, and we're beginning to lose control of it in women as well. We have inequality that would stagger you. Glasgow is a very, very special place. It's where I live. It's where I've spent almost all of my life. It's a wonderful city with wonderful people, but it has the greatest mortality inequality in the Western world. If you get a second disease, if you get depression along with your diabetes, if you get rheumatoid arthritis along with your kidney disease, you get it 10 years earlier if you're poorer. And this is the railway system in Glasgow. So I live where it says Hindland in the top left of that slide. I live pretending to be posh in a conversion of an old sandstone building, okay, in the wealthy bit of town near the university. My parents and my grandparents lived in Bridgeton, which is at the bottom right of the screen, in the poorest part of Glasgow. It's 8 miles from my house to where my granny died, in the same house she lived in her whole life. She died at 87, so she bucked the trend. It's 8 miles, what, 2 hours walk maybe? And I'm in Canada, so you do actually walk. In America, that doesn't make much sense, that walking thing. So we would walk that 8 miles. We're European. We would tend to walk that 8 miles. If you walk, your life expectancy falls in those 8 miles by 15 years. It's an astonishing city. And there are lots of reasons for that. The principal reason is young men, violence, drugs, alcohol, all the things you would expect. But there's something different. There's something special about the inequality in Glasgow. It's worse than the other major industrial cities in the UK. So these are some of our challenges. We don't actually have this on a hill in Holyrood is the area of Edinburgh where the Parliament is, and that's why this makes sense to Scottish people but not to Canadians. So Scotland's approach has been to write policy documents, which is all very well. I spend far too much of my life now inside boardrooms in the Scottish Government writing policy or getting policy written by people who can write. This is our quality strategy, 2010, published on the back of the Scottish Patient Safety Programme, beginning to transform the care that we give in our healthcare system. Then we published more recently, when we had a change in minister, we got a new healthcare minister 18 months ago, and we published with him our 2020 vision for healthcare for safe, effective and person-centred care which supports people to live as long as possible at home or in a homely setting. And then we also published a route map to that 2020 vision. Sorry if the black writing doesn't show up particularly well. 12 priority areas, they're not controversial. Person-centred care, integrated care, early years, things that you would expect to be on there. So that's all very well. So you do have to have a vision. You can download these documents. You're welcome to them. They exist. They are there for the politicians. They're there for our delivery system. They're there for the 153,000 employees of our system. But they mean nothing if we don't then implement that change. So Scotland has decided, Scotland has taken a theory of change and implemented it. We could have chosen multiple theories of change. We could have gone with Lean, we could have gone with Six Sigma, we could have gone with the traditional send a chief executive's letter out and tell everybody to work harder theory of change. We could have gone with hope. We could have gone with multiple things. We could have gone where England have gone and used the market. So England have effectively decided that the free market will drive quality and make it better. That again, can you hear from my tone, my view of whether that might work for them or not? Now, they do have big challenges. They're 10 times our size, and they're not as smart as us, so that makes it, that makes it a little bit difficult for them. I know what won't work, so I know that if we always do what we've always done, we'll always get what we've always got. So I know that new thinking is required. I know that because it's public money, we need a level of performance management. So £12 billion given by Scottish taxpayers to deliver the public service. You can't do that without priorities set by the public. So the public care about access and cleanliness. That's the two things, if you ask the Scottish public, what do you care about? They care about access and cleanliness. So you're going to have targets and performance management around access and cleanliness. You can argue whether they're the right priorities if you like, but it's not up to you. They're what the citizens of Scotland have decided presently are the top two priorities. So that's why you need a level of performance management. You do need some targets. We have very, very few, but we do have some performance targets around 4-hour waits in A&E, around 12 weeks from referral to treatment. So our long waiting lists are all gone. The myth of the UK health services having 3-year waits for hip replacements, that used to be true. That is all gone. So that's curve number one, targets, performance management. We've chosen to do much of our transformation around quality improvement, our safety programme, our early years collaborative, our person-centred care programme, and I'm going to touch on those programmes in just a second. And now we're headed to what we believe is the third curve, the actual transformation curve, where you give power away, where you take Lucy and Lewis with you rather than do it to them. In fact, you put Lucy and Lewis in charge. And you devolve that paternalistic thing that we've all had for so long. So in other ways of putting it, the targets and the performance management, necessary but not sufficient, necessary as a foundation for change, you keep the power. In quality improvement, you perhaps include people and you share the power, but in the co-production and assets world, you give the power away. But if you're going to do that, what is your implementation plan? So this is an IHI model, will, ideas, and execution. Many of you will have seen it before. Many of you will have taught on it. What is that execution phase? What does that look like? Well, Deming said that the most important thing, and he wouldn't see you in his old age. He was a cantankerous old bugger, I understand. He wouldn't see you in his old age if you couldn't describe the method, if you couldn't tell him what it was you were going to do. So let me illustrate that with a true story of NHS Scotland. So most people in the room will know what early warning scoring is, will we? So patient in the bedside, you take their heart rate, their blood pressure, their respiratory rate, their temperature, you add them all up, you give them a number out of 4 or 5 or whatever it is, and that number becomes their early warning score. It's a kind of assessment of how sick they are. So if there are 4, they probably shouldn't be in hospital at all. If there are 3, you might want to come back in 4 hours and just check their vital signs again. If there are 2, you should probably come back in an hour. If there are 1, they're probably dead. Got it? Roughly. Sometimes it's the other way around. So Ninewells Hospital, a massive hospital in Dundee in Scotland, decides in 2005 that it wants to implement early warning scoring across the whole hospital. This is a true story. They form what we colloquially know as a short life working group. Are you familiar with these entities? They're neither short life nor do any work. But that's what they did. They set up a short life working group, and it met 6 weekly in a boardroom. And it had real people on it, like actual nurses. People who might use this form once it was made. Doctors who were concerned about early warning scoring and deterioration. 18 months after their first meeting, they had a product. It was absolutely beautiful. I've seen it. It was the nicest early warning score sheet I've ever seen in my life. It was red, amber, green. It was printed on slightly expensive paper that you're not really allowed in the NHS. It was a nice font. They were so proud of it. They printed 300,000 copies. 300,000 copies. And they arrived on a Friday, and Jerry, who's my pal, who was the chief exec in NHS Tayside, where this hospital is for many years, he's just moved to Australia, actually, for a new job. So he on the Friday gets the 300,000 copies in his office, and he writes a letter. And he writes a chief executive letter to each ward and says, look what the clever people have done. That's not actually what it says, but look what the clever people have done. On Monday morning, please implement the new NHS Tayside early warning scoring chart. We're the first in the world to do this. Isn't this going to be wonderful? Lives are going to be saved. So everybody comes to their work on a Monday morning, and they get a little pack of the early warning scoring sheets. How many do you think are used? None. Not a single one. Not even the nurses in the room of clever people used it. They still exist. I've seen them. Jerry now uses the cupboard they're in as a visual aid of how not to do large-scale change. He takes you to the cupboard and says, these are my effing 300,000 early warning scoring charts. This is what I thought was change. So Jerry, with a number of others, then went to a thing called the Safer Patients Initiative in England, where they used the 4 countries, brought the hospitals from the 4 countries together. It was 2006. And he learned from the Institute for Healthcare Improvement, it so happens, how to do large-scale change. And he learned to get out of the boardroom into the workplace and to do small cycle testing. So to go to nurse number 1 and say, okay, we'd like to do early warning scoring in your system. How will we do that? Well, let's take a piece of paper and a pencil and write down what might be required. Okay, so we're a vascular unit. So our heart rate range is slightly different from the one that they use in renal. So that form that you produced, that was useless for us. The red, amber, green didn't work for us. We're maternity. In maternity, we have 4 hole punches in our case note, not 2. So that thing you produce, is this familiar to you? The little address label we use in the dialysis unit, we use a special address label. So our address label doesn't fit on your thing. Okay, this turns out this is slightly more complicated than sending out a letter and an early warning scoring chart. To cut a very long story short, or shorter, within 3 months, Ninewells Hospital had early warning scoring charts in every ward implemented 100% of the time. And cardiac arrests fell dramatically outside intensive care. Because they designed it with the workers in the room, standing up in pencil, scored it out, did it again. By the end of a single day, they had learned 45 times, instead of learning 45 times in 18 months. Now, would I like one chart for the whole of the hospital? Would I like one chart for the whole of the country? Probably if you pushed me, I'd say yes, that would be nice, because the trainee doctors could move from hospital to hospital. It's an illusion. It's a complete illusion. You're never going to get there. So surely better to have it reliably delivered in the ward you're in or the unit you're in if you can. That's our theory of change. So we're moving from this industrial production line mentality, although there are things to learn in production lines, don't misunderstand me, to the world where relationships are what make the change, where having rooms like this driving the change are actually the key, and forming relationships between the improvers. This happens to be the biggest conference centre in Scotland with the early years practitioners from Scotland's public services. So we believe our theory, not translatable to you perhaps, is you need a clear stretch goal, you need a method, and you need iterative testing. And the safety programme is our neatest example of that. Our safety programme has an aim to reduce hospital standardised mortality by 20% by the end of 2015, and that 95% of patients will go through hospital with none of these 4 harms. They're kind of beacon harms. They're not the only things that we want to stop people having, but they are kind of our beacons for harm. And let me just give you a tiny, tiny fraction of the data that we have. This is the surgical checklist in Scotland, a magic solution to surgical harm. The original data from Atul Gawande in the article published says you would get a mortality reduction of between 15 and 40%, depending on where you are and what you did. So this is now the surgical data. This is the briefing data, and this is now the mortality data in Scotland. It's a 23% reduction in surgical mortality in the last 3 years. I know of no other country in the world that's been able to achieve that nationwide. Now, I can't tell you it's the checklist. I can't draw a neat cause and effect line because I didn't do half the country with the checklist and half the country without, which is what the academics wanted me to do. I said, okay, we'll just treat academics in the half of the country with no checklist. For those of you who are now hating me, I was an academic for 15 years. I consider myself still one at some level. So we have a 23% reduction in surgical mortality. Our overall mortality, so our overall infection rate, that's an 80% reduction in MRSA. Now, the truth is, and please don't tell anybody, is the reason we've been able to show an 80% reduction is because we were a bit rubbish. So that we started high. So it's easier to show an 80% reduction if you're poor at the beginning. This is our C. diff numbers, down by about 80%, and that's been a big, big topic. I know you had Robert Francis yesterday, and we have an equivalent report coming in Scotland around a particularly very, very serious C. diff outbreak in a hospital in Glasgow a number of years ago, not unlike the Francis Inquiry, going to be our version of that called the McLean Inquiry, which will come out relatively soon. And I won't get any sleep for 2 weeks, I don't think, as soon as it's published. This is our actual mortality data, the all-cause mortality inside our hospitals. It's the first time this data has been shown to anybody. It just came out on Tuesday. What day is today? Friday. Which country is this? This is a 12.5% reduction in mortality over the last 5 years since the beginning of the Scottish Patient Safety Programme. It varies by season, and it varies a lot, but it's a 12.5% reduction. It's lives saved. It's less than predicted deaths over the last little while. And we believe we've done that by small cycle testing. We haven't done that by telling people, please make care safer. That doesn't work. We don't have glossy brochures. We don't have big fancy things. We have real change in the front line with real people inside learning networks that we call collaboratives. So we now have 4 safety programs. We have the acute care safety program, which is related to that data. We have a maternity and neonates, and so pregnant women and kids one, and we now have new ones around primary care and mental health, which are hugely innovative, massively challenging because the community is different. But to illustrate the success at some level of the branding and the communications we've had, when we had the first learning session for the acute program, we had a room of 900 people and 2 doctors came. In the mental health version, we had a room of 300 people and there were 150 doctors. Now, I'm not suggesting doctors are the only important group. I'm a dentist. I'm the last to think that. But there is something about the workforce that has changed in terms of the safety program. So let me move on, just as I begin to think about closing, towards what we're doing outside our healthcare system. So be careful what you wish for, because the government is not used to success. So if you say you're going to fix something or help and fix something, and then the results begin to show that you might have been right, stuff happens. Like other politicians come and say, can I have one of them? Can we do that? Is there something in this change theory that might actually work? So there are other intractable challenges in the public services, one of which is the early years. So we've known for many years that 9 months in the womb and the subsequent first few months, and certainly the first 5 years, have a huge influence over your life chances as you grow and are educated. And if you can sort, fix, whatever you want to describe it, those very early years, you will not only improve the lives of millions of people in your population, you'll also save money, you'll also make the resources go further. It's like a little magic moment in people's lives. And we've had initiatives after initiatives after initiatives in Scotland for many years around what that early years stuff might be. So we've had a slogan in Scotland for many years that Scotland would be the best place in the world to grow up. We don't lack ambition in Scotland, have you noticed? But we haven't really had an execution strategy. We haven't had an implementation plan. So having done a bit of work around safety, the early years people came along and said, that this is genuinely what happened. They came and knocked my office door and said, we would like a piece of that. We would like someone to teach us how to do that level of improvement. So we designed the Early Years Collaborative, and we set some aims that made people's hair stand on end. So we went in to see the politicians who were responsible for early years, not for patient safety, and said, we want to reduce infant mortality by 15% by the end of 2015. We want 85% of children to have reached their developmental milestones by 30 months. We want 90% of children to reach their developmental milestones by the time they hit primary school. And we want a leadership system that will enable that to happen. Their heads nearly spun off. Nobody had ever set how much by when aims for early years. Nobody had even imagined how much by when aims for early years. So it took us some time to persuade those stakeholder groups that this was the way to go, but we've managed to persuade them. Early years, it turns out, is not unlike patient safety. There are a series of interventions that are evidence-based that when you do them reliably, stuff gets better. It's a novel approach to change. One of the things is bedtime reading. Now, I have no idea how I ended up from taking out wisdom teeth and doing glossectomies to talking about bedtime reading in nursery schools. But it's the same type of change. So this is Bedtime Bear. This is an actual intervention. So what happens is you go to nursery school, kindergarten, I don't know what you call it in Canada. So you go, you're 2 or 3 and you're at preschool. Yes? Are we familiar? And you are given a bedtime bear. You're given a book and a bear. You're the child. You're given a book and a bear. And it's a slightly manipulative intervention because you're told that the bear needs a bedtime story before it can go to sleep. You got it? It's playing tricks with the child a little. I'm okay with it. And the child is told to go to their carer, their parent, their auntie, their uncle, their foster, whoever's looking after them, and say that the bear needs a bedtime story before bed. And bedtime reading is like magic. If you read the literature on bedtime reading, you'll be astonished. It makes the kid cleverer. It makes the adult cleverer. It makes both sleep better. Honestly, it's unbelievable when you start to read what happens. But in the poorest communities in our society, we deliver it 7% of the time. Not because they're bad people. Nobody made it easy for them. They didn't get bedtime reading when they were a kid. Nobody has told them, nobody has taught, nobody has proved that that's the way to do it. So we have introduced bedtime reading in nursery schools. We haven't taken a big glossy brochure and told them this is the bear you've got to use, and this is the books you've got to read, and this is the resources you're going to have, and there's no big advert. We've just told them, in a collaborative like this, do bedtime reading. Get your nursery kids and your parents to start to do bedtime reading. This is a run chart of bedtime reading in a nursery school in Edinburgh. Now, you'll notice there's a little bit of a blip. Scotland is dull, grey, and cold 365 days of the year. That's the only hot weekend we've had for 45 years. So we're kind of letting them off. We're surely letting them off one night where they didn't get their bedtime stories because it was actually sunny. And they were out in their paddling pools playing and they didn't know what had happened. They thought the world was coming to an end. Never mind the bedtime reading. But you can see the bedtime reading. So that's on the wall in a nursery school. And that's now being replicated all over the country. But let me take you back to behind those dots. This is Alfie. Alfie is a 4-year-old inside that same nursery school He's autistic. He's quite a challenging young man. And these are quotes from his mum, not prompted, asked but not prompted. And she describes a completely different environment in which when she sat down with him with the bedtime bear, when they started to do stories, he begins to transform. He sleeps better, he turns the pages. So even just helping a young man like Alfie is hugely beneficial to that society. And if you can do that at scale, then all the better. Now I'm going to show you another video clip now. I didn't show you this one at the beginning because I'm hoping by now some of the Scottish accent is working. Now, if you think I'm bad, this video is quite difficult. So some of you may not get it all, but we're going to try. There's some kids in it, some Scottish kids that are really difficult, and then some of the Scottish parents are not much easier. But it's a video about a bedtime reading example inside a different nursery from that one you've just seen, but the same kind of intervention adapted for their world. And I think it's inspiring. I think the story these mums tell is completely inspiring.
I can count up to 100.
She's buried in the sand. But in the middle of the night, in the middle of the beach, on Friday after school. Dippy had the water. Reading a bedtime story is a #1 predictor for learning to read, and for young children is early literacy. We started the Big Bedtime Read in Mayfield Nursery School with one family, and at the same time in the Children and Family Centre, again with one family. And that has scaled up to 30 families in the nursery. We were given a chart, for a weekly chart, Monday to Sunday, asked to fill it out. The aim was to try and read a story every night to your child. And this year, obviously, Kerry's now preschool, so they're both getting the advantage of it. Who picks the books? Let her go. No, cried Ursula, and handed over his magic trident to the sea witch.
But why is she always in trouble?
Because if she's exploring old shipwrecks, she's not doing what her daddy asked, is she? Did you like reading the stories?
And I read all of them.
Yeah.
I read 101.
Did we read that many, did we?
Yes.
I get to see the enjoyment in their faces when they get a story they like.
And sometimes they do actually talk about the books that they've been read to them, not to us, but amongst each other and amongst their peers when they're around.
The nursery are doing it this year with handing out the little book bag and having the reward chart. That helps because that incorporates people who wouldn't normally consider taking part in something like this.
Then if Kerry comes back from the nursery to the house with a book, I'm more likely to read it to Kerry.
This year we carried on in Mayfield Nursery School, but we also started in 2 primary schools with nursery classes. In Cookin and in Stop Hill, there are plans to take it into primary 1.
It's the first time we've undertaken it in Stop Hill. At present we're working with 5 families from nursery. As head teacher I was quite keen to get involved with it. I actually work with the families. I think that's really important. I might want to have a look in the pack.
You could put Tyler to bed at 8 o'clock and by 10 o'clock he'd be back up. But Phil started doing the books, you read the story with him and he goes straight to sleep.
It was quite stressful before that because she would always want telly and it was a fight for it to go off.
He actually sits down and reads the story with you. Because you read it so many times, he actually knows bits of the story.
I can get all 4 of mine down together and I can read them a book because they all used to watch DVDs. And now it's like a big massive change because they'll go straight to sleep after a book with me. And it's really good because they tell me when it's time for the story. Never used to do that to me.
Good, it's your time. You find that really a nice time
it helps
for you all to be together.
Yep.
And are you and Stuart taking turns to read to her at night time?
Last night a big step. She just cuddled in on the couch to him. He read the story and she went up to bed and stayed in bed.
And straight to sleep again? Brilliant, that's fantastic. Okay, what about Sapphire?
Before I started this, I was trying to read her a book, but she wouldn't take any part. She would just rip the books up. But last week, she liked one book because it had a train in it.
Yeah. She did like trains, so we'll look out for train books.
And she does like looking at the packs in nursery. I'll show her the packs, and she knows she does come across and she points to some of the things. And how did her bedtime routine go?
Oh, good. quite hyper last
Okay,
night.
so
Just
more
not want to sleep
excited
at all.
Maybe just try, instead of saying bedtime, just say story time or something, see if that makes a wee difference.
No, the way I do it is I put, say it's time to brush your teeth, because then they come to you for the storybook, because they know it's time for bed then.
I think reading a story to a child at night time gets them more settled.
They're parents of children who had some difficulties with speech and language development or who were finding routines a bit difficult. Some of our parents have themselves not had very good experiences in school, so what we're doing is trying to build their self-esteem, to empower them, to make them feel good about themselves and their parenting. You've made a bit of a difference in a really short time just by engaging with them and reading books with them. We came up with our own recording sheet that we thought was parent-friendly and also child-friendly. Some people are not very keen on filling them in, and that's all right. Just a tick when you have a story.
Every day I speak to the 5 children about their bedtime story the night before.
Someone said roar.
Met young Sapphire, who likes train books, and a couple of weeks after this was taken, she is now she only reads train books. She's 3. She won't read anything else that doesn't include trains. And but Chantel, who's her mum, has now managed to get her for the first time to sit and listen. The fascinating thing about this video is every time I watch it, I'm impressed by the way they're trying to help each other. Did you see? I'm not sure you could get all the language, but when one is saying it's really difficult, I'm really struggling, she gets opportunity. They co-produce the solution together. It's not imposed on them by the middle-class head teacher. They are facilitated to have that conversation themselves. It's genuinely revolutionising these homes through such a simple intervention. Now, bedtime reading is just my kind of beacon I'm using for you. There are lots of other interventions inside early years. There's breastfeeding, there's smoking cessation, there's attachment, there's all kinds of other things that are happening inside those first 5 years of life. So what's your job as leaders to translate perhaps some of those examples into your world? And let me finish with this. This is IHI's most recent leadership document, their new white paper of moving from volume-type leadership to value-type leadership. And it has 5 principles, 5 behaviours that I think are proven in the Scottish example of safety early years, and increasingly we're about to do, would you believe, we're about to do Scotland being the best place to learn. So we're about to do an educational attainment collaborative for older kids. So you have to put the people in the middle. So you have to put Lucy and Lewis in the centre of everything that you do. It trumps finance, it trumps everything. You have to be in the front line. So you have to abandon the boardrooms. The Japanese have a phrase called gemba, and gemba is going to the workplace, going to the front line. In Toyota production lines, there are yellow footprints painted on the floor at the production line, and they are for executive leaders to go and stand in to watch. So when I say walk-arounds, I don't mean shaking hands and having a cup of coffee with the union leaders. I mean stand and watch the system. Be in the workplace. It's really hard. It's fun, but it's hard. And it is not quick. But it's quicker than the alternative, which is nothing. So don't be conned into thinking the alternative version, the illusion of work, that illusion of sending a letter out and saying, do the early warning scoring, that's quicker. It's not quicker because it gets nothing. This version of change is really hard. You require relentless focus. It's a life's work, but it works. Probably the hardest, particularly in our publicly funded system in Scotland certainly, is openness and transparency. So fling the doors open. Abolish visiting times. Publish all your data. Let the families in. Let the media in. Let the population in, and just expose it. Now that's really hard. And there are consequences to it over time. But it's really difficult initially. And then finally, and I've learned this most of all inside the early years work, where we've got tables in our collaborative with a policewoman an addiction therapist, a midwife, a doctor, a social worker, and they've all got different value systems, they've all got different employers, but they all want to fix it for Lewis. So knocking down those boundaries is really quite difficult. And the only way I think you can knock those boundaries down is to bring the families to the table, either virtually or actually. Because they can't talk about car parking and the colour of their uniforms in front of the families. They just can't do it. It completely changes the dialogue. So those 5 things, I think, are the principles around what the leadership systems look like inside our massive, large-scale change process. And IHI use that as the model for this. So they say this is your job, to create vision and will, to deliver those results and develop capacity, driven by the population, the community that you're working with. And that task, that leadership behavior changes the culture. So talking about culture change doesn't change it. Actual tasks change it. So critical care culture changed when we eradicated the infections inside critical care units around the world. Not because we talked about culture change. And then increasingly, that has to start to happen across boundaries, because the artificial boundaries we've created by public services of having a health system over here, a home care service over here, a police system over here, a housing service over here, are completely artificial, and the population don't understand them. So I hope this is how you feel. I hope that you believe in community, you believe in collaboration both across countries and inside your own environment, and I hope you feel like this. I don't suppose you've given up 2 days of your life because you're scared. So I hope that's the impression you've had from the sessions yesterday and this morning, and increasingly as the day goes on. And I'll finish with this story. I showed this slide. I've been using this slide for a couple of months because I quite like it. It kind of sums up my values system. And there was a little row of people at the end of my talk waiting to ask me questions. And when you speak a lot, you kind of get a feel for how those questions are going to go. And there was a gentleman at the end of the row who looked worrying to me. No disrespect, gentlemen, but he had a brown suit on, which is always a worry. Men in brown suits it's just a dodgy thing. So, and he looked really, really earnest. He was very, very earnest. And he came to the front of the line and he said, so this slide was still up on the screen, and he said, your final slide. I said, yep. He said, you shouldn't use that. I said, okay, thanks for your feedback. Why? Does anybody in the room know why? Any natural history buffs in the room? So you're right. You don't get penguins and polar bears on the same ice cap. So he was very concerned about my use of natural history. And I'm not sure where my speed of thought came from, but he had irritated me slightly. So I looked up at the screen and I said, mate, there's a penguin with cymbals. Is that really your problem with this slide? And there was not a flicker. So he's still unhappy. And by this time, I'm getting really quite irritated. And I looked up and I saw the young lady penguin. See, she's got a handbag. And I said, I honestly looked him in the eye and I said, mate, she's got a bag. Maybe they travelled. Thank you very much for listening.